I'm Joyce O'Shaughnessy. I'm at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. This question is very much of a work in progress in practice. There's not one definitive answer to that question, for the simple reason being that we don't have evidence right now that a certain group of patients will have a better outcome if they get preoperative therapy, be it chemotherapy or be it anti-estrogen therapy, endocrine therapy, if they get it preoperatively versus doing surgery first and then getting their systemic therapy, that goes all through the body, their systemic therapy postoperatively. There's no evidence that if you do preoperative or postoperative chemotherapy, endocrine therapy, or both, that there's a superior outcome. That's why it really is not a well-defined answer to the question of who should get preoperative therapy in patients who have operable disease. So in general, I think the way things are evolving is mostly if patients have larger breast cancers, over 2 centimeters, or if they have, clearly palpable axillary lymph nodes, preoperative therapy, be it chemotherapy for the more aggressive, faster growing, higher grade breast cancers, or endocrine therapy for breast cancers that are very strongly estrogen receptor positive, generally progesterone receptor positive, grade 1 or grade 2, lower Ki67s would benefit from endocrine therapy preoperatively. Mainly it's done for patients where we're looking to do less surgery. For example, a woman who might otherwise have to have a mastectomy because the cancer is on the larger side, but she's highly motivated for a lumpectomy. She wants to do breast conservation. That's a really good reason to do preoperative therapy. Or if a woman has a palpable lymph node in her axilla and you'd like to do less in the way of axillary surgery, the surgeon would like to do less in the way of axillary surgery, that may be a reason to do, for example, chemotherapy first in a patient who has highly proliferative grade 3 disease, because the surgeon can clip that lymph node, put a clip in it before she starts her chemotherapy, and then can be sure to retrieve that node that was positive, that had a clip in it. And now if it's become negative, there's no cancer in it after the preoperative chemotherapy, that may allow the surgeon to do less axillary surgery. So the way things are going is that patients who we hope to do less surgery for, either they have a larger cancer in their breast or clearly cancer in their axilla, we tend to want to give them preoperative chemotherapy if they have grade 3 disease, fast growing breast cancer, higher Ki67, particularly over 20%, for example, progesterone receptor negative disease, aggressive disease that would tend to respond well to chemotherapy. We'll give those patients increasingly preoperative chemotherapy outside of a clinical trial. There's a number of clinical trials going on adding, for example, immune therapy to the chemotherapy and in the preoperative setting. And that's obviously a reason to do it if you've got an important clinical trial for the patient. But outside of a clinical trial, it's really to downstage, to decrease the amount of cancer that's in the breast and the axillary lymph nodes in order to do less surgery. And patients who have grade 1 or grade 2 breast cancer, generally estrogen and progesterone receptor positive, slower growing with a Ki67, for example, under 20%, those women may benefit the most from preoperative endocrine therapy. You're trying to decrease the amount of cancer in the breast and axillary lymph nodes. Endocrine therapy is likely the best therapy for those patients. Some physicians will send a test such as the 70 gene signature, that's the mammaprint, or the 21 gene signature, that's the oncotype, to see if it's low risk cancers, and then they'll be comfortable offering preoperative endocrine therapy to patients. And patients just have to be watched closely as they're getting their preoperative endocrine therapy to make sure by physical examination that the cancer is decreasing in size, or by ultrasound or by MRI to be sure the cancer is decreasing in size. And if it is, it's very reasonable to give 6, 9, even 12 months of preoperative endocrine therapy as long as the tumor is continuing to shrink. So in the ER positive patients outside of a clinical trial where the breast cancer is ER positive, HER2 negative, it's really mainly to be able to do less surgery for patients that we consider giving preoperative therapy.